Hi, guys, it's Dr. Sadaf, and I would love for you to like and share this podcast and make sure you leave me a review. I'd love those 5 stars. So please, when you send me a review, please make sure to put the 5 stars in and to share the episode with somebody that you know that could really use it. And I would absolutely appreciate it. Also, if you're looking to schedule an appointment with me, make sure you go to my email and put your name on the email list. You will be the first to know when I open up my office in spring of 2024. It's drsadaf.com. And last but definitely not the least, September 16th to the 23rd, 2024, I will be hosting a retreat with Dr. Basma Faris in Morocco. You will be getting yoga and coaching, and we'll be doing excursions and cooking and spa and hammam and all of that great stuff along with meditation. So make sure you don't miss out. Spots are limited. So go to the link in my bio in both Instagram and TikTok to make sure you register. Enjoy the show. I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf Lodi. And today on this episode is everything you need to know about maternal mental health. But before we get into the episode, I want to make a couple of things very clear. One, that I am not giving any type of medical advice. If you have any questions about your mental health or if you're suffering from any type of depression, please speak with a healthcare provider that can assist you. And that I am not giving any type of religious advice. If you have any questions about your religion, please speak with your friendly religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today on this episode, we have with us Dr. Furey. Hi, Dr. Furey.
Hi.
And for those people that are listening and watching that may not know who you are, if you could just give us a brief intro about yourself.
Sure. So first, thank you so much for having me. And similarly, I'm not giving any medical advice either, but I'm really excited to be here to talk about maternal mental health. I am a board certified adult psychiatrist who trained at Yale University, and I currently practice in the state of Connecticut in my private practice called Sound Psychiatry, where I focus on women's mental health, particularly in the peripartum time period as well as the perimenopause transition. I offer psychotherapy as well as medication management. And I also am a consultant for the state of Connecticut's New Access Mental Health for Moms hotline, where providers around the state can call if they need some direct peer consultation about how to manage the mental health needs of pregnant and postpartum women struggling with mental health or substance use disorders. And then I also have a podcast myself called Analyze Scripts, where me and a colleague analyze the depiction of mental health, good and bad, in popular TV shows and movies like Succession, Encanto, Frozen, some cult documentaries, Barbie, like a bunch of different things that comes out every Monday. So I do a bunch of different things.
Oh, so fun. Well, that's great to know. I'm
Yeah.
glad you're out there. What a great resource. So let's get into it. So I know that May has been Maternal Health Month, and I
hmm
know that May is also Maternal Mental Health Day. We have a day in there, and then I think there's also Maternal Health Week. So why don't you tell us a little bit about Maternal Health Day, which I think was last week.
Yeah.
And at the time of this recording, we're in the middle of May.
Yeah, exactly. So, the first Wednesday of May has been designated International Maternal Mental Health Day, and there are petitions out there where we're trying to get a ton of signatures to urge the WHO and UN to really maybe not the UN to really recognize that internationally to build advocacy, awareness, support, resources, things like that. And then in the state of Connecticut, last week, the week of May 6th, was Maternal Mental Health Week. And our governor, Ned Lamont, declared that May 5th moving forward will be Connecticut's Maternal Mental Health Day. So I think it varies a little bit from state to state, at least in the United States. But suffice it to say, May is really like focusing on maternal mental health, which is great. because up to 1 in 5 new moms struggle with a postpartum mental health disorder, and that's just from the statistics that have been reported, which, as we know, we're not gonna be capturing everyone because a lot of
Right.
people, aren't gonna be captured in that, so it's probably way higher.
Yeah, I definitely think so. I know that one of the complications of actually pregnancy postpartum is maternal suicide, right?
Yes, yes. Actually, it's sadly, so postpartum mental health conditions are the number one complication of pregnancy, which most people are really like shocked to hear. Usually we think
Right.
of like gestational diabetes, hypertension, preeclampsia, all that stuff happens too. But most people will struggle with some sort of mental health disorder. And that's because women are at highest risk during this time of their life. And 20% of postpartum fatalities in depressed women are due to death by suicide, which is way higher than at other times in a woman's life. So it is pretty staggering. And only 75% of women who screen positive for depression in that period are able to access treatment, which is also way worse than at any other time. So I think it just speaks to the fact that, again, we need more awareness, we need more resources, we need more access to resources.
Yeah, I think that so when I was doing obstetrics in the clinic, I still deliver babies now, but in the clinic specifically, at some of the healthcare centers, we actually will screen moms every trimester
Great.
for through the Edinburgh and the
Yes.
PHQ-9.
Great.
However, that is very rare, and that was actually a clinic that was federally funded. So I'm sure that there was some type of mandate to do that for women. However, I can tell you, like in private practice, I mean, we rarely did that. We never did that, actually, I'll be honest, every trimester. And,
Right.
you'd be lucky if the women would return postpartum because, as
Yeah.
when women have their babies, a lot of times, especially if it's their first baby, and I know when I had my first baby that it was so overwhelming.
100%.
And, you have this little creature that is
Literally, like, stuck to
crying.
you. Uh-huh.
Yeah, I know. I was crying and hungry and dirty, and he's changing and throwing up and pooping all over the place that you just never have any time to yourself.
100%.
And, to even get up in the morning and shower and brush your teeth
Is an
is like
Olympic feat. It is.
it sure is.
It
It
is,
sure
right?
is.
You're so speaking my language. First of all, you're totally right. Like, that's amazing that that clinic did the screening as often as they did, because obviously that's what we recommend. Studies show that 60% of cases of postpartum depression, when you trace it back, actually started during or before pregnancy. It just gets worse postpartum, so that's when we finally catch it. But it's always better to intervene earlier. But again, that's not like standard of care yet. For some reason, we hope that will change over time. And you're so right. I always tell my patients that under the best of circumstances, rainbows and butterflies, the sun shining down on you, having a baby is incredibly hard and very overwhelming and draining and all the things. And then add in any other extra stress. And sometimes these are positive stressors like moving, a new job, things like that. Whatever it is, it just makes it harder. So a lot of the work I do in my practice is just normalizing that reaction for a lot of women, because I think we're under the assumption that you're supposed to immediately bond with your baby. It's supposed to be the best day of your life. You're supposed to get that euphoric reaction that we see in the movies and we read about or we see on Instagram or TikTok. And the reality is that is so rare. And you're really lucky if you get that, but most people don't. And I always tell people to think about, like, when was the last time you met a stranger and like that was it? You were in euphoric love with them. For most people, that's not normal, you know? And so it's the same thing with a baby. And then you have that they're crying at you all the time. You can't figure out what they want. And again, in the media, they always portray it as like you can distinguish the baby's cries. Like, that's really hard. So there's like expectations are really high.
Yeah.
So even under the best of circumstances, it's so challenging, like you said.
Yeah, no, I think it's actually, like the first 3 months, I have to say, for me were a big blur,
Yeah.
and I would never do that again
Yeah.
because it was so miserable.
Oh my
And
God.
then, when you add, then you have your second or your third, whatever, and then you have all these little kids,
To
under
take
the
care of
age of
too.
like 5.
Mhm.
Right, and they're all crying, and they all need something, and then you just sit in the corner and you cry yourself because you're
Yeah.
like, "What the heck? I can't do it."
100%, right? And I don't know about you, but I think like a lot of women feel like they should love maternity leave.
No, I didn't at all.
Yeah, I don't think most of us love it. It's so hard.
It's
And
very
again, it's like, again, when was the last time you interacted with any other human being where all they did is cry and scream at you? And that was it. That was all the emotional, social like input you get. And yet they need all of this from you, and you never know if you're doing it right. Doesn't seem
yeah.
like you're doing it like, duh, that's going to be really hard.
Yeah, I mean, I remember I used to prefer being on call, and I
You
hate
could,
call.
yeah.
I used to because 1, I had, like, other adult
Yes.
interaction, and 2, I could actually get some, like, rest, which is
100%. I totally get that.
right?
I totally
Like,
get
I
that.
wasn't changing diapers, I wasn't feeding, anyways,
I
yeah, it's
totally get that. I had my first child in residency and same thing. Like once I was like, back to work, I would sign up for moonlighting shifts. And I always would tell my husband, like, I feel like you have the harder job right now being with him overnight. And I'm here like watching the little TV till they call me, kind of sleeping. No one's like on top of me. Like I totally get, and I'm making money. Like it's great.
yeah, I know,
I
right?
totally get that.
It's crazy. It's crazy. So let's talk about, different types of perhaps symptoms that somebody may experience. So
Hmm.
it's interesting. I have to tell you, so I'm on social media. I'm on TikTok and Instagram at Dr. Sadaf OBGYN. And I will say one of my reels that keeps getting circulated over and over and over again is the one on postpartum psychosis.
Oh,
People are
great.
going nuts with that.
Oh, that's so great.
And it's like it's one of my older ones, and it's okay, but, I think that it's just because somehow, we don't talk about postpartum psychosis and that
Hmm.
it can happen
Hmm.
and what to do about it,
Mm.
and I think maybe that's one of the few roots because even if I go on today, there'll be, like, lots of comments on it, people will be
Mm.
sharing it, people will be talking about it, "Oh, yeah, this happened to me, and I thought this happened," and blah, blah,
Oh,
so
this is so great.
yeah, so maybe you could talk a little bit about baby blues
I
versus
would love
postpartum
to.
depression versus postpartum psychosis.
Oh, I would love to. I love talking about postpartum psychosis as much as I can because, like you said, it's incredibly scary. And at least in my experience, so many women think that's what they have because they're having these scary intrusive thoughts or their hormones and emotions are all over the place. And that makes it scary to reach out for help. So I would love to talk about that. So when we talk about baby blues, what that means is after you have a baby, your hormones drop precipitously. I tell my patients it's like you're on the top of the tallest roller coaster and then you crash. And estrogen and progesterone in particular, they just crash, they bottom out. That change in those hormones is what can cause some women to experience a lot of mood instability, a lot of tearfulness, but then maybe you're laughing. You just feel all over the place, but that's normal. So up to 80% of women will experience that the first 2 weeks after delivery. And what I tell my patients, like, just brace for it and remind yourself, like, apparently this is normal because we all go through it. It's just related to that hormonal shift. The most common postpartum mental health condition is postpartum depression, which again occurs in up to 1 in 5 women and 1 in 5 dads, which I think is really important to point out because that again argues that it's not just that biological change. For women, of course, that's a huge part of it. But for dads, they're also adjusting to this big change. And then in terms of the rates of the other illnesses, postpartum anxiety, we use to sort of capture a lot of different anxiety disorders, like generalized anxiety disorder happens and I believe it's like 6 to 8% of patients, whereas things like panic disorder is a little less. um, we have postpartum OCD, which can also affect women. And then postpartum psychosis is the most severe postpartum mental health condition and the most rare. So that affects 1 to 2 every 1,000 births. So that is about 0.001 to 0.002%. So way less than postpartum depression and anxiety, but hard, I think, for the average person to differentiate. I think even clinicians have a hard time. So I'm happy to talk about that a little more if you'd like.
Yeah, yeah, no, please continue. No, I think that'd be fantastic.
Yeah. So when we think about, baby blues versus postpartum depression, again, postpartum depression can be diagnosed all the way up to a year postpartum, most commonly within the first 12 weeks. And now what's super exciting is that there is an oral FDA approved medication,
Mm,
zuranolone, which just got approved in the fall. So that's a really exciting treatment option these days. Postpartum depression can look like depression. Most OBGYNs will screen for it now, like you said, using the Edinburgh, the EPDS. And again, there's symptoms of low mood. You might have an irritable mood. So I always tell people that sometimes it's like a weepy, tearful type of depression. Other times you're just like a raw nerve ending. You're just, everything's irritating you. And everything, you're also just so hard on yourself. You're sort of hearing everything critically. You're feeling really guilty. You feel like you're not doing anything right. You might feel disconnected from your infant. And it starts to affect your functioning, which is already affected by having a baby. But these are the women who, when given the chance to sleep, which is rare when you have a newborn, just can't because they're ruminating in their head. They feel like they have to do something. They feel like they're not good enough. It might affect their appetite. They might be moving slower or having trouble getting out of bed, or the opposite, they might be really restless. And then in the worst case scenario, women will have suicidal thoughts, whether they're of the more passive kind, like, ugh, I just don't want to get out of bed today. Like, why did I do this? I just want to run away, which I will say, sidebar, every woman who's had a baby at one point feels like they want to run away. That doesn't make you a bad mom. It is really hard. Or they might have more frank suicidal thoughts. So that's like what postpartum depression looks like. Postpartum anxiety is more of the worries that you're just worrying all the time. And it is so common after having a baby, but we don't talk about it a lot. And especially in the postpartum period, most of these worries feel intrusive, which means you're having these thoughts you don't want to be, but you can't like shift your attention away from them. You get stuck in them, you ruminate about them. And a lot of times they are centered on the baby. And a lot of times they're about harm coming to the baby. So, for example, a lot of women worry about dropping their baby when they're walking down the stairs, when they're doing the dishes. I hear this all the time. They might be putting knives away and they think, oh my God, what if I cut the baby? And this isn't like they want to, they're just having this intrusive thought and they're so scared of it. Other times, women might have had a pre existing anxiety disorder like a phobia or social anxiety or something like that. It might get a little worse, but a hallmark symptom of postpartum anxiety are those intrusive thoughts that are really scary. And if those intrusive thoughts are then coupled with a repetitive compulsive behavior, like doing the dishes in a certain way to avoid the knives, or, when you're walking down the stairs, actually, these are more avoidant behaviors where like you might avoid the knives, or I have a lot of women who won't go down the stairs with their baby if their partner's not home, or they might go down the stairs, but they might scoot on their bottom. Things like that start to feel a little more like OCD, especially if then you have a compulsive, repetitive, ritualistic behavior that the woman is having a hard time not engaging in. So the things we think about would be things like hand washing, weighing the baby, tracking. There's all those tracking apps these days that help you keep track of like when did you last feed the baby, which breast did you use, like stuff like that. Sometimes if it gets too compulsive, that can kind of become a compulsion. The big difference between a postpartum anxiety disorder or OCD and psychosis is that women with the anxiety disorders, again, it's way more common. Those women, when they have intrusive thoughts about harm coming to their baby, it scares them. They don't want to act on it. They're freaked out, but they think they might be losing their mind and their baby's at risk because of that. They're actually have a way lower chance of doing anything to hurt themselves or their baby because it's due to anxiety. With postpartum psychosis, again, that is a psychotic disorder. So, what does that mean? It means you have hallucinations, delusional lines of thinking. You might have paranoia, disorganized behavior, disorganized thought processes. In that subset of women, the intrusive thoughts about harm coming to the baby don't bother them because they're usually in a bigger delusional context that's in line with what the woman thinks she needs to do for some altruistic delusional reason. So again, a lot of times it's like, I need to kill my baby so they'll go to heaven or something like that. It often has a religious element to it, but that's when we worry, is when those intrusive thoughts are in line with what they think is right. That's the scary part. And again, postpartum psychosis most commonly develops the first 2 weeks after having a baby. Again, it can develop anytime the first year, especially anytime the first 3 months, but those first 2 weeks, really important. Your suspicions should be really high if the woman hasn't slept for more than 48 hours. Any prior history of psychosis or bipolar disorder places you at risk. And again, if her behavior starts to change, if her mood starts to change, we often see mood lability, which means they could be manic as well, like really euphoric mood, way too happy, and then kind of have depressive episodes. They might be a little delirious. Like sometimes they seem to be oriented, they know what's going on. Other times they're really out of touch with reality. And then those delusional thoughts, especially if they're about the baby, are really concerning. Postpartum psychosis is associated with the 5% rate of suicide and 4% rate of infanticide where the baby is killed, sadly. And again, that's way higher than other conditions that we know about. So that's a medical emergency. Got to make sure mom gets safe. And it's hard to evaluate for.
Wow, no, that was so great. I'm so glad you went over all of those different types of generalized anxiety and mood disorders that happen, postpartum. I think that's really, really important because oftentimes we don't think about anxiety, right?
Right.
We do think a lot about the postpartum depression and the blues and things like that, and rarely about psychosis, but definitely anxiety, I think, is also up there. I think it's a really great point that you bring up about the estrogen and progesterone, just really bottoming out right after delivery once we remove that placenta. And, all of a sudden now you have all these hormonal changes that happen. And what I think is really important to make note of, and I think why women, specifically the first 2 weeks out, probably are at risk is because we know that there's so many estrogen receptors in the brain
Yes.
that respond in the amygdala, in the hippocampus, and also in the hypothalamus. And so, and those receptors are also those places in the brain are also responsible for your moods, right? And anxiety and all of those things. And that's why we also see it in perimenopause. And as we
Exactly.
go through that transition into menopause, because our brain is not getting that estrogen that we need. And so I'm so glad that you made that correlation between, postpartum and perimenopause, because we often don't associate those things, right? Perimenopause, menopause, we're thinking, oh, you're done with your fertility. And postpartum, we're thinking, you're pregnant and now you just delivered. So we just don't think about how those hormonal shifts are so similar,
Right. Right.
and why our brain, and even in, I'm sure you, of course you know this as a psychiatrist, but this was something that new that I learned, is that even women that did not have anxiety or depression in their earlier years, during that perimenopausal
Yep.
time they can develop it, new onset
100%.
depression
Yep.
and
Yep.
anxiety, because of those hormonal shifts.
Yes.
So
Yes.
I'd love to hear a little bit more about what you can tell us about hormones and the
Oh, I
brain
would love to.
and emotions. Yeah.
I would love to. I love this stuff. And you're totally right. And I just have to say, I feel like, and I'm probably preaching to the choir, but the medical field's understanding of women's health, let alone women's mental health, is still like way behind what we understand about men. Okay. So we just have to all get on the same page about where we're starting. It's in a dark cave. Okay. But we're starting to creep out into the light. Okay. And so, what I always tell my patients is that all women, no matter what, are at highest risk for developing a mental health condition, whether it's depression, anxiety, psychosis, bipolar disorder, whatever it is, around the time of having a baby. And we know that, so usually for most women, that's in your 20s to 30s. That tends to also be the time men have their first episode. So I think there's something about that. But then you add in these hormonal changes, and that certainly contributes for a lot of people. Now, if we go back to menarche, right, when women get their first period, puberty, we also know, is a time of big mood swings, right? Like we all accept this, okay? Um, I feel like we're only just now thinking, we as like the medical field are like, huh, there's actually biology that proves this. Like, no way, right? Um, so what we know, and again, we're still, I think I'm hopeful over the course of my career that we learn a lot more about this stuff. But it turns out a lot of women are sensitive to those shifts in hormones, specifically that drop in estrogen and progesterone turns out is super important, that happen after you ovulate, after you deliver a placenta, and when you're going through menopause, right? When we think about the course of a woman's life, all those time points are times when there's that drop, right? That roller coaster drop. And some women, I always tell my patients, this is a spectrum. Over here, we have the very few, very lucky women who are just like not affected. Okay. There's like very few of them, but great. Most people in the middle will experience some element related to this hormonal shift. We call that like PMS. We call that baby blues. We call that this is kind of normal. And women are just expected to function in our society because we live in a patriarchy. Okay. And then over here on the more severe end is when we have clinical disorders that we are only now starting to understand. And what's exciting is we have treatment for. So that could include things like premenstrual dysphoric disorder, the postpartum mental health conditions, and the perimenopausal mood and anxiety disorders. What's also really interesting is that our understanding, I would say, of the pregnancy related disorders, we know more about that than we do like PMDD and perimenopause. But I think we're coming to find like there's some similarities here. It does seem like it is related to the estrogen withdrawal and the progesterone drop. And what they've come to find is that women who have postpartum mental health disorders and perimenopausal disorders and PMDD, they don't have enough of allopregnenolone, which is a metabolite of progesterone. So when progesterone gets broken down, allopregnenolone is super important. And it turns out that women, especially in the postpartum period, who have depression, anxiety, things like that, they don't have enough of that. And that compound has been hard to create a synthetic version of because it can be super sedating. It's super exciting that now we have IV brexanolone and now we have oral zuranolone, which was just approved by the FDA for postpartum depression. I wouldn't be surprised, although it can't predict the future. I'm not the one doing the research. I wouldn't be surprised if in the next 5 to 10 years we start using it for other, hormonally mediated disorders too. But you're right that in perimenopause, this is one of my newer areas of interest because I'm finding it's really similar to after having a baby. There's a high rate of recurrence. If you've had any other mental health condition before either your first period or before pregnancy, you're at a higher rate for a recurrence during that time period because of these changes. And like you said, if you've never had anything your whole life, you're still at a high rate for having your first episode during that time period. It's like there's this second spike. And interestingly, there's also a second spike in women for schizophrenia at the same time. We don't really understand that yet, but I wouldn't be surprised if it has something to do again with these hormonal shifts. So yeah, and again, another thing I always like to mention is these hormonal shifts also affect our ability to pay attention, our executive function. So I also see a lot of ADHD getting worse around these timeframes as well, or women being diagnosed for the first time because the executive function demands kind of grow as you're the typical woman in the world. Even if you don't have children, if you're working, the demands get, greater as you age, as you move up the ladder, if you're caring for your elderly parents or other people in your community. And so a lot of women who maybe had ADHD that didn't get diagnosed because they were functioning okay, they kind of figured it out in the context of postpartum or in the perimenopause transition. Often they can't cope anymore, again, because of those effects on the brain.
Amazing. I had no idea. And especially, well, I had some idea about like the perimenopause
Yeah.
because I'm a menopause society certified practitioner. So we
Oh,
know that,
awesome.
of course, there are so many hormonal shifts and estrogen affects so many parts of
Yes.
our body and, of course, progesterone as well. And we know the effects of testosterone
Right.
with helping with muscle mass and also with libido and things like that. But I had no idea about ADHD and how that can be exacerbated during these transitions and also can be responsive to all these hormonal shifts. Really, really interesting. And I think that also when you talked about these transitions, I think it's really important to know that if you were at risk postpartum, you're probably also going to
Yes.
be at risk during the perimenopause, menopause
100%.
shift.
Yep.
I wonder if you notice that is it only during the perimenopause, menopausal period that women will develop this new onset anxiety and depression, or will it stay with them throughout, postmenopause?
So that's a great question. I believe, as far as I know, if you are the woman who's never had anything before and you develop your first episode in that perimenopause time, I think you have a higher chance of it being a one and done kind of thing. To, Compared to women who've had previous episodes, then it's like, oh, you're at higher risk for this coming back. again, I would imagine in that cohort of women who've never had an episode, this is their first one. Again, there's probably women who will continue to have more as you age. There's other stressors, there's other medical conditions that could, add to the burden. But I do believe you're right that if it's a one and done in that time frame, it might just be that singular episode that'll go away as you finish the menopause transition. But again, that transition can take a while.
It can, especially, and what we know with the SWAN study that was started in
Yes.
1994, it's
Yes.
still ongoing, right? We also know that different women go through perimenopause, that transition for different amounts of time. And specifically, African American women go through it the longest for 10 years before they have their last menstrual period, whereas Caucasian women, they say it's 7 years. Hispanic women 8.9 years, and East Asian women 5 years. So really interesting how like different
A big difference.
ethnicities, right, go through it differently. And the thought is there's a term called weathering. I'm sure you've heard of it, but they say that it's because those individuals that have been exposed to, let's say, for African American women, to systemic racism throughout the years, it actually changes their DNA and it shortens their telomeres so that it makes them more at risk for, a longer perimenopausal period, or makes them more at risk for high blood pressure, diabetes, and anxiety, depression, all of those things because of the systemic
Yeah,
racism
like as
that.
if racism wasn't enough?
Yeah, so now we have a reason for
Mhm.
why they, and of course, I believe it's a hypothesis, but there was a paper written by Harlow et al. In 2022 that was published that talked about how systemic racism affects the length of time that African American women go through perimenopause. So really interesting.
That is really interesting. And I think at least I'm not sure about in your practice, but in mine, when I ask my patients, well, how old was your mom when she went through menopause? Most of them don't know, again, because we just
Nobody
don't
knows.
talk about this, right? Like
Yeah,
no one is talking about it. It's
yeah,
just like,
yeah.
oh, mom's like sweating and angry in the kitchen. Like, but no one's talking about it. So,
That's correct. I mean, absolutely. When you, just like what you said, when you ask patients about how old was your mom, your sister, they just don't know because it's taboo. They don't talk
right,
about it,
exactly.
or that their mom will be like, well, it was so long ago, I don't even remember. And it's interesting also how different cultures view menopause.
Mm,
Here in the
yeah.
West, I feel like, women are almost afraid to say that they're menopausal. Like I just talked to a friend of mine last night. We were at an event and she said to me, I said, oh, are you going through perimenopause? And she goes, no, 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 I'm still fertile. I want
Yeah.
to still
Yeah.
say
Yeah.
that, I'm fertile. I'm not, as
Yes.
if it's like a bad thing
Right.
to be menopausal, right? But
For
it's that,
sure.
that our emphasis in our culture on fertility
Yes.
and the beauty of that, right?
Hmm.
As opposed to somebody that's menopausal is so strong that people really have this aversive reaction to saying that they're menopausal.
Right.
And I just thought that that was so interesting. And also, I just think that we just don't talk about it, right? I think
Mhm.
most people just don't talk about it. So I'll tell you, like, for example, like my mom, I asked her, about menopause and things. And she was like, oh, I don't remember, but, you'll be so happy when you're done. Like for her, that was like a great
I was gonna
thing.
say, like, who doesn't wanna stop getting a period? Like, that kinda sounds great at some
Yeah.
point.
Right, right, and she was like, "Oh, you'll love it, it's such a great time, you don't have to worry, blah, blah,"
Mhm.
and it's so interesting the different reactions with people in different cultures, and how
Yeah.
they feel about it, so it's really
That is really
interesting.
interesting. And I think like one thing I love about your podcast and what I'm talking to more and more of my patients about is also how it's so normal for women's libido and sex drive and even like comfort when you're having sex to change over the course of your
Yeah.
life, especially at these hormonal shifts. And I think
Yes.
what gets tricky, at least for me as a reproductive psychiatrist, is often our first line treatment for a lot of these things are SSRIs, which can have negative effects on libido. So I spend a ton of
Yes.
time talking to my patients about like, well,
Yes.
do you think it's the SSRI or do you think it's like you don't want to have sex at the end of the day because you're exhausted, everyone's been touching you
Yes.
all day, your body
Yes.
feels different, it might still hurt, it might be drier, like you don't feel as sexy, you're thinking of all the stuff you got to do, the baby's crying, like do you think it's that? But like again, we don't talk about it, right?
Yeah. Yeah, I love that. I love that you bring all that because that, I'm noticing more and more that when I do these podcasts, I really enjoy. I mean, I love all my, guests, and I'm so grateful that when they come on. But I love the talks about the brain because
Yes.
we know that the brain is the biggest sexual organ, and that there's so many parts to
Mhm.
it. Like we need that emotional intimacy that's required in a relationship to
Mhm.
want to be receptive to like a sexual stimuli that
Mhm.
happens, right? We have to have the feeling of safety and security to
Mhm.
want to be vulnerable in that space. There's mindfulness, so
Right.
I'm not sure if you have heard of these researchers, but there's, Dr. Lori Barato, who has written. She's a psychologist, and she has written a book called "Better Sex Through Mindfulness." And she writes how, and she was actually on my podcast as well, and she talks about how important mindfulness is and how they've done research on this and noted with group therapy that women that practiced group mindfulness, and there were like 90-minute sessions, but that at the end of 6 months, they noted that these same women had increased libido and lubrication and arousal because they were practicing mindfulness. Um, there's another psychiatrist. She's out of British Columbia. She's now retired. Her name is Rosemary Basson, and she created the female sexual response cycle. Who, and she was the one that, because before, as you know, we, in medical school, we learned the Masters and Johnson. That was research done in the 1960s on, old white men, and not that there's anything wrong with that, but that doesn't apply to women.
Yeah.
And so she came up with the female sexual response cycle in 2001, and she talks about how
Mhm.
emotional intimacy is required. And she also talked about responsive and
Right.
spontaneous desire. And she
Yes.
also talked about how sometimes, women are not always, um, they're not, they don't have to be, have that desire come before they go into like a physical relationship. They have to actually be in that space. Like they have to be able to respond to it. So, for
Mhm.
example, if they are in a healthy relationship where they feel safe and secure and have that emotional intimacy with a partner, if there's a sexual stimuli, then that desire and arousal can come afterwards. It doesn't have to
Mhm.
come before.
Mm,
And
mhm. Right,
so
right.
that was something that was very novel that she discovered, as
Yeah.
opposed to, in our linear model, we hear that, desire and arousal have to come before, a person is able to become intimate with somebody.
Yeah,
So many different things. And I think that it's really important to realize the impact that the brain has on
for
the
sure.
sexual response cycle.
For sure. I totally agree. And again, I think, these are questions I ask all my patients, and I always try to normalize it and say, like, listen, I know we don't talk about this stuff a lot, but it's okay to talk about it. And it's also okay that your sex drive changes, over the course of your life, and that your husband's might not if you have a male partner. Like theirs might stay pretty steady, but you might need more to get in the mood. And that's normal. Like it's just normal.
Yeah, absolutely, absolutely. And so that, again, just what you're talking about is that speaks more to the responsive desire, right? So
Yeah.
once that stimuli is there, then they start to get into the mood, and then that desire and arousal shows up. But it doesn't have to be, what we see in the media where people
Right.
are tearing off each other's
Right.
clothes, and it's this, crazy spontaneous desire, which
Right.
we know in long-term relationships it tends to be more responsive desire than spontaneous desire anyways.
Right,
So
right. And again, as we're talking about that, I'm just thinking, it's also important to remember that a lot of women go through traumatic experiences as in regards to pregnancy, postpartum, even a delivery that goes okay by medical standards could be experienced as traumatic for the woman. It could be frankly traumatic. Or, we do know that women do unfortunately have high rates of sexual violence. And so all of that can lead to trauma symptoms that can also affect your libido, your relationship with your partner, all of that stuff. And so again, I feel like I love podcasts like yours and just anyone on social media talking about this stuff to just normalize it and say basically like whatever reaction you're having, like let's explore it because some of these reactions are normal, expected given the circumstances. And then that's where a professional like me can come in and help discern, where is it now sort of broaching a pathological realm where we use that word just to say like we could help you feel better. It doesn't mean there's something wrong with you or that you caused it or you should feel ashamed
Mm.
about it, but you don't have to live like that. We could help you feel better.
Yeah. Yeah, that's amazing. That's amazing. And I'd love to end on that because I think that that is fantastic. Is that, that's what psychiatrists are here for, is
Mhm.
to make you feel better. So for anyone that's been listening to you and is thinking, wow, she is amazing and I really want to work with her, how can people get in touch with you and how can they reach out?
Yeah, no, thanks for asking. So I am on Instagram at Dr. Katrina Furey. It's spelled DrKatrina My private practice website is sound-psychiatry.com. And like I mentioned, I do have a weekly podcast, Analyze Scripts. We are on Instagram and TikTok and YouTube, I think, at Analyze Scripts Podcast. So you can find me a couple different places.
That's amazing. Well, thank you. Thank you so much
Of
for
course.
being
Thank
on.
you.
And any last pearls that you'd like to leave the listeners of the audience with before we sign off?
I think the more we can just talk openly about this stuff as we feel comfortable, also respect your own boundaries. But the more we can talk about it and normalize it, the better. And to just know that there is help available. The Postpartum Support International has a hotline that you can call to be, if you are a provider seeking to find a specialist for your patient, or if you're a patient themselves, the National Maternal Mental Health Hotline is also available. And then states have their own access mental health lines. Not all of them yet. Hopefully, it'll keep expanding, but there is help out there.
Awesome. Well, thank you so much. And well, we are done here and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. So if you're having any issues with depression or anxiety or any psychological disorders, please speak with your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.